Alrighty. Hi, everyone, and welcome to our 99th virtual shadowing session. Tonight we have for you a specialty spotlight in dermatology with Dr. Heather Goff. Next slide, please. As always, we have our virtual shadowing working group that makes all of this possible, and which includes our physicians, Dr. Fowler, Dr. Salazar, Dr. Wynn, and Dr. Reno as well. Next slide, please. And then stay tuned because next week we're going to have a session on wilderness and environmental medicine, which is our 100th session, followed by hematology and oncology. And then the next week after that, we'll have palliative care. Next slide, please. I just wanted to remind everyone to be sure to hold your questions about the assessment to the very end, but to put your quiz questions in the chat as we go so we can answer those along the way. We're going to stop at the middle and at the end, as usual, to answer your questions. And that's it. Dr. Fowler, what would you like to say?
Thank you, Taylor. Welcome, everybody, to virtual shadowing. It's so good to have you here. This wonderful program is made up of our marvelous guests who come and talk about what they do. And this terrific virtual shadowing team, everybody do a shout out for yay, virtual shadowing team, because they do this every single week, week in and week out, to which we're terribly grateful. And we're plotted out already into July, so we have some great talks coming from you. Several of you have asked that John White, who spoke on radiation safety, speak again. And if you really feel that way, please let us know tonight in the chat. I've already mentioned it to John. We have an admissions committee, former chair, going to be speaking to us soon. So we just really have a lot of terrific programs coming up. I believe it's the 14th, Aditya, of June that we'll be doing another virtual interview. So we're still looking for some volunteers, to come join us and be our guinea pigs for some online virtual shadowing in front of about 300 of your closest friends. Anyway, we're glad that you keep coming back. As long as you keep coming, we're going to be here. We're about to cross 64,000 of you that have signed up. We've had over 500,000 viewings of our programs online, and we printed over 250,000 certificates of attendance. So we feel strongly that we're helping to contribute to your future as a healthcare professional through virtual shadowing. Taylor, would you want to introduce our wonderful guest this evening?
Sure. If you could please give a warm welcome to our first derm physician on the show, Dr. Goff. Take it away.
All right. Thank you so much, Taylor and Dr. Fowler, for having me tonight. Let's see here. Am I still in control of this slideshow? There we go. So a little bit about myself. So I'm an associate professor of dermatology at UT Southwestern. I've been on faculty since 2014, so I'm going on my 8th year at UT Southwestern at this point. My undergraduate degree, though, I was a non-traditional pre-medical student. I had an undergraduate degree in fine art from Texas Tech in Lubbock. And then I went on to get my master's in public health from UT Health Science Center in Houston. And then while I was doing kind of my post-bac pre-medical requirements at the University of Houston. Once I finished all that, I applied and got into medical school at UT Health Science Center in San Antonio, where I also completed my residency as well as a preliminary year in internal medicine residency training at UT Health Science Center in San Antonio. At the end of my residency training, which was back in 2007, so I'm dating myself a little bit, I joined faculty at Northwestern University's School of Medicine as an assistant professor faculty in dermatology, where I actually specialized in dermatologic diseases revolving around hair and hair loss disorders, in addition to practicing general dermatology. Then I actually moved to Colorado, to rural Colorado, an area called Durango. It's in southwest Colorado, near kind of the Four Corners, so near New Mexico. And at that time, I was an adjunct professor at Northwestern, so I maintained sort of an adjunct professor title, and also was engaged in clinical dermatology and also teaching down at University of New Mexico. I would drive down occasionally. I'd take a Friday off and drive down and do teaching with the dermatology residents at the University of New Mexico, and actually had a couple of their residents rotate with me while I was in private practice in Colorado. So I was in private practice for 4 years, and then got tired of private practice and really wished to be back in an academic environment where I could be more engaged with teaching full time. And at that time interviewed at UT Southwestern and actually University of New Mexico, kind of both, and decided that UT Southwestern was the better fit. And then joined as an assistant professor, but shortly after was raised to the rank of an associate professor. So, and that's the position I've held since then. So what made me take a non-traditional path into medicine? Well, when I was in undergrad, when I was in fourth year of undergrad, I was sort of contemplating, it's in life, there's sort of these, some people start off always knowing the direction they want to take and the path they want to be on and what they want to do. And that's wonderful. I've just never been one of those people. I feel like life is sort of doors have opened or doors have closed. And I tried to just read the signposts along the way. So I was in my fourth year of undergrad and contemplating what the next steps were going to be after I graduated. And I was a night janitor in the student union. This is like the true story. And there was a little kind of convenience store on campus, and I went into it. And at the end of my shift, I'd sometimes read magazines, and there was like a Psychology Today or something. And there was a big article, the kind of front cover article was an article on regret. And I don't remember much about the article, except that the kind of takeaway message was that young people regret things that they have done, whereas older people tend to regret things that they haven't done. And so I kind of pictured my future self, and I always thought I always did pretty well in math and science, and I was always very curious, just intellectually curious, and curious about the human body and how it works. And I always thought that medicine was a very fascinating and interesting field. And so I sort of thought, well, maybe I'll go to medical school. But it really felt like a shot at the moon because I hadn't taken any classes at that point and hadn't done any of the pre-med requirements. And so I didn't really meet with a pre-med advisor, which was probably a good thing because they probably would have told me like, what are you thinking? You haven't taken a science class since high school. But basically what happened was I'm really dating myself now because it was pre-internet. So what I did was I graduated. I was like, well, I have to graduate. I graduated undergrad and then I moved back home. My parents lived in Houston. And I marched down to UT Houston and Baylor College of Medicine. I went into their admissions offices and I was like, well, do you have a catalog that tells you like what classes you need to get into medical school? And the admissions officer, oh yeah, here's the catalog. And on the front page here, it tells you the classes that are the prerequisites for medical school. And I was like, well, okay, and so I went home and I looked at all the classes and I went to University of Houston and I figured out what their kind of course schedule was and how I was going to get it all done within a couple of years. And I made out an academic plan for myself. And I was like, well, I'll start taking these classes. And if I get good grades in them, it'll be a sign that I'm supposed to go to medical school. And if I don't do well in them, then it'll be a sign I'm not supposed to go to medical school, and I'll figure out what I'm supposed to do from there. And so I got the MPH along the way because I was really inspired I have an aunt and uncle who did many years doing non-governmental work for the U.S. Agency for International Development in Nepal for like 20 years. And they did literacy and public health work. And so they encouraged me to potentially get a master's of public health, just, because at that point I was relatively undifferentiated. I didn't know if I wanted to go to medical school or if doing public health work was maybe going to be more my niche. And so I kind of decided to start the pre-med and then maybe look into doing some, doing my master's degree. And so I looked into how to apply to public health school. And so the whole sum of my post-bac, I think, took like 3 to 3.5 years, somewhere thereabouts, before I applied to medical school. So I was around age 27 or 28 when I finally went to medical school. And so that was sort of how the MPH happened along the way. But it all started basically by reading this article on regret and thinking about like, how if I was older, I might regret not putting my feet on that path. And I can always say to this day that I'm extremely grateful for my career in medicine and extremely grateful to be a dermatologist, and just very happy that things have turned out the way they have. I don't regret a single moment of choosing this as my career path. There's days that are hard, but there's days that are hard in every job. And I feel like I'm very fortunate to be in a career that's intellectually stimulating, diverse, interesting. And I get to forge relationships with people every day, not just coworkers, but patients and residents, and not everybody gets to do that. And so I feel extremely grateful. So what is dermatology? Well, as you might guess, I started medical school not knowing what I wanted to go into as a specialist. I was like very excited to get in, and I was like, wow, this is really cool. And I'm going to get to learn about the human body and how it works and how it breaks down. And I get to learn all this fun language. And that's really cool because a lot of the language in dermatology is, and the language in medicine seems so arcane and, not understandable. And so I was really excited to learn all of that. So, so I basically completed my, first 2 years. I did really well in medical school. I got pretty much A's. I know now it's pass fail for a lot of schools, but I did well in medical school. So what I didn't know when I started medical school, I was a relatively average student in undergrad. I did really well in my pre-med, but I remember when I interviewed for medical school, one of the people that interviewed me was like, your pre-med GPA is better than your general cumulative undergrad GPA. They're like, how do you account for that? And I'm like, well, I actually knew what I wanted to do. And I knew I really wanted to get into medical school and I needed good grades. So for sure, if you're early in your undergraduate career, try and make as good of grades because it's definitely, it's one more hurdle to have to overcome if you don't have good grades. But fortunately, when I got into medical school, I just sort of took it on as a challenge to see if I could do well, and I did. So that was lucky because I didn't shut any doors for myself. What I didn't realize when I started medical school is I thought medical school was like the hardest part, right? I thought that was like the big hurdle. But as it turns out, actually getting into the specialty you want might actually be the bigger hurdle because different residencies have different number of slots or residency positions each year. So there's relative, and maybe lifestyle and work hours and stuff like that also drive people's decisions. So residencies can sometimes be more competitive to get into than medical school itself can be. I sit on the committee that reviews all the residency applications to our dermatology residency program, for which we have 7 to 8 slots per year. For dermatology, that's actually a really big program. Where I trained, there were only 2 residents per year. We have 7 to 8. So we have one of the top 3 largest dermatology residencies in the country. So we have 7 slots per year and we get about 500 applicants for those 7 slots. So it's highly, highly, highly competitive. At any rate, when I was I think first or second year medical student, I was chit-chatting with one of my co-medical students who this guy was like a real gunner. I didn't think of myself as a gunner. I just was like, I just want to make good grades. But I wasn't like competitive. I wasn't one of those people that hoarded knowledge. I just liked, anyway, but I'd studied or something with this gentleman and he was like, oh, have you heard, somehow he said something about like, oh, well, you don't know what you want to get into. You should get Isarsons. And I was like, what's Isarsons? And he's like, oh, you don't know about Isarsons? And I'm like, I don't know about Isarsons. And so I ordered this book, and it was actually a really useful book because if you, like me, don't know what you might want to go into as a specialty, this book sort of describes in a little bit of detail each of the different specialties, what the training is that's typically involved, the level of competitiveness to get into that residency. So for those of you that are applying right now, or once you're, I would say this isn't like reading material until you're in medical school or you're accepted. And then if you're not sure what you want to go into, sort of start cogitating about it.
Hey, Heather, Ken Iserson was an emergency doc for many, many years out in Arizona.
Oh, that's cool.
Yeah.
I did not know that.
Yeah.
So I got this book and I read it and I was like, okay. So I was actually like 3/4 of the way through my 3rd year of medical school. And what I think that for one of the branch points in medical training is, are you more of an outpatient person or are you more of a hospital person? And I was like, well, I think I'm more of a clinic person than a hospital person. I liked the clinic and I liked that longitudinal care. And so I was like, well, I'm a clinic person. And so then that like sort of already like knocks out a whole bunch of things. And then I'm like, do I like adults or kids? And at that time, I sort of felt like I liked adults and kids pretty equally. So I wasn't sure. And so I thought I might go into family practice or psychiatry. And I just happened to be talking to my mom, who was a school teacher. And she doesn't know much about medicine at all. And she was like, well, honey, have you thought of dermatology? I think they treat all ages. And I was like, oh, no, I haven't thought of that. So I did a rotation in dermatology and I fell in love with it. I was like, this is, oh my gosh, it was like meeting the person you're going to marry. I was like, oh my gosh, I didn't realize that there was a specialty where you can look and diagnose things just by looking at them. And so, being able to just, look at the skin and look at skin disease, and be able to recognize something like psoriasis looks one way, eczema looks another, just by looking at it was just a real joy. So that's how I chose dermatology. So I did a rotation in it and I'd done well, as I mentioned. And fortunately from my, when I got my MPH, I actually had a couple of publications. And then during medical school, I'd managed to publish a little bit more. At one, I had a brief flirtation with the idea of doing trauma surgery. And so I had done some publications in trauma surgery and then basically applied and got into dermatology. And then the rest is history. So what is dermatology? Really, dermatology can see, as I mentioned earlier, you can see all ages, you can see from birth until death. But I would say in most clinical practice, and I include my years in private practice, that in general, more people tend to have skin problems as they get older. And so I would definitely say the patient population, skin cancer, benign lesions of the skin, growths of the skin, et cetera, tend to affect the old more so than the young. But I actually like that. I really love my older patients. They're always so grateful and so thoughtful and so generous. And, a lot of the older patients tend to listen to you a little more too. So I kind of like that also. Hours in dermatology are great. Some of my days start at 7:30, but I'm usually done seeing patients by 5:00. It doesn't mean I'm always out of the office by 5:00, but a long bad day might be like 7 p.m. if I'm stuck doing some charting or some patient callbacks or what we call my chart. So messaging back patients on questions that may have come in during the day. There's 3 fellowships, and what a fellowship is it's basically additional training in a subspecialty once you finish a residency training. So there's 3 ACGME, American College of Graduate Medical Education. And those are dermatopathology, that's diagnosing by pathology, dermatologic diseases of the skin. There's something called MOS or dermatologic surgery, and pediatric or procedural dermatology, and then pediatric dermatology. There are kind of quote fellowships in cosmetic dermatology, but they're not ACGME recognized. But some people feel like they may not have gotten enough cosmetic training in their residency, and so they may choose to do a cosmetics fellowship if they choose to kind of have that as the focus of their career, or the path that they want to be on. But in terms of ACGME recognized, there's 3: dermatopathology, MOS, and then pediatric dermatology. Interestingly enough,
so Heather, I'm on the group that picks our emergency medicine residents here at Southwestern for Parkland and Clemens. And I say that we don't need an Einstein. We need someone reasonably intelligent, yep, with a great work ethic, who's a nice person. But I think, yep, in dermatology, they pick Einstein also, don't they?
They like Einsteins. They really do. In our department alone, I'm definitely surrounded by people that are a lot smarter than me. We have about 4 or 5 faculty that are MD PhDs that run lab. They see only a half day of patient, do half day of patient care per week. And majority of their salary support is supported by writing grants, and doing bench research in the lab. They have all completed, they're all MD PhD track, and then have done postdoc after their, so they'll do a derm residency. We have a 2+2 track, which basically means dermatology is usually 1 year of internship, which everybody does, and then 3 years of dermatology training. But the 2+2s do their 1 year of internship, 2 years of dermatology training, and then they go to the lab and they do 2 years essentially as a postdoc. And they start learning how to, kind of run their own lab. And during that time, they have some attenuated patient care, and that counts as sort of their last year of residency training. But that's a very hard road because you're constantly writing grants. Their salary, a lot of people, not that salary is everything, because you really, if you're intellectually curious and you want to ask the big questions, that's the track to be on. But salary wise, they may earn, you can go on Texas Tribune and look up anybody's salary. You can look up what I make. So it's not a secret because we're a state institution. But they may earn like 150 to someone else's 300,000. So they're earning a little bit less for doing less in terms of patient care, but doing more, I would say, in terms of writing grants and supporting their salary through grant writing and NIH funding and bench research. But they get to ask the big questions and sort of push the field in direction and make new discoveries. And so that itself can be kind of an amazing path to be on. Look, I have the chat open, so I keep seeing all these questions about someone's asking if I feel pressure to have nice skin. Oh, sure. Yeah, you feel you have some pressure to have nice skin. That's normal. That's why I didn't go into psychiatry. So I was like, oh, I'm going to be constantly picking people apart. I already look at skin way too much. I knew that about myself. So, okay, but I love psychiatry, and there's a lot of psych association dermatology. Anyway, so scope of practice, it's clinically based. Most dermatologists are going to see a lot of general dermatology. So we're going to see a lot of acne, a lot of rosacea, a lot of skin checks, a lot of benign skin lesions. My particular area of specialty now is cutaneous lymphomas, which is an extremely rare group of entities that involve, you have a lot of immune cells that live in your skin all of the time. And sometimes some of those white blood cells that live in your skin turn cancerous, and then you have a lymphoma that affects just the skin. I also am the director, because of my years in private practice. During those 4 years, we had a very laser heavy practice when I was in Colorado. So when I joined the department, they needed someone who was going to sort of spearhead the residency training in cosmetics. And I came with a little bit more years of practice and years of experience. So that was a role I took on once I joined the department. So I kind of direct some of the residency training in cosmetics as well. So it's sort of very disparate. One is very intellectual and one is like very not intellectual. But I really like that balance because I can sort of use my brain a lot on one end and then sort of turn it off and just use sort of the art part of my brain and my background in art and fine art in treating cosmetic issues of the skin that also have a lot of times medical overlap. If you look at like kind of specialists, even though these aren't fellowships, anybody can sort of pick an area that if you have a disease entity that you like or enjoy, people will tend to send those cases to you. So we have specialists in our department that deal with cutaneous lupus. We have another doctor who specializes in connective tissue diseases and their effects in the skin. Another doctor who specializes in autoimmune blistering disorders, another one who specializes in just vulvar. She liked OBGYN, and there's a whole group of entities that affect vulvar skin and vaginal skin, and that's her area of focus. There's another specialist in our department, one of the MD PhDs, who focuses on keloids and scarring. Another one of our physicians who runs a pigmented lesions clinic and treats all the patients that have a history of extensive dysplastic nevi and melanoma. We have 2 full-time pediatric dermatologists. We have another doctor who specializes in hair disorders. I actually see some of those patients as well due to my background at Northwestern. And we have another specialist in eczema and atopic dermatitis. So it really runs the gamut. And like I said, you can pick an area of specialty, but most people also practice sort of general bread and butter dermatology, which is acne, rosacea, and skin checks, I would say. So what are some notable things that people may not think about with dermatology when you first think of the skin? I think a lot of people just think of the skin as sort of this envelope that holds your, your insides in and your outsides out. But if you really kind of dive deep and think about what is the skin doing, yeah, it is keeping the outside out and the inside in. But how does it do that? Well, it's a huge immune organ. There's actually like double the number of white blood cells in your skin and my skin and Dr. Fowler's skin. All of our skin right now contains double the number of white blood cells that normal skin does. And so your skin is just chock full of immune cells. There's, antigen presenting cells, there's T cells, there's B cells, there's mast cells, there's garbage men, which are the macrophages. And these all take residence and live in your skin as resident memory cells, many of them. Their skin is full of antibody as well. So there's tons of antibody in your skin and tons of these sort of resident memory T cells. So if you think about like, when your immune cells are differentiating, how I explain cutaneous lymphomas, for instance, to my patients is that, baby white blood cells are born in your bone marrow. Then they become teenagers sort of in your lymph nodes. And then they figure out what they're good at fighting. If you're a white blood cell that's good at fighting gut infections, you're going to go live in the gut. If you're a good white blood cell at fighting lung infections, you go live your adult life in the lungs. Liver, likewise, there's liver white blood cells, brain white blood cells. So white blood cells traffic, they find out what they're good at recognizing, whatever antigen, and wherever lymph node they interact with, they know that antigen presenting cell that interacts with that T cell, they know that came from like skin. And so that T cell is going to develop when it's like, okay, I'm going to propagate many of myself. It's going to propagate skin homing molecules that attract it to the skin. And then once it enters the tissue, it will lose some of those egress molecules and it takes up residence in the skin and it lives out its adult life in your skin in perpetuity, because later on you may get another staph infection. You also will have a central memory T cell that recognizes the same antigen, and that lives in your circulation but it has also skin homing molecules. So if you have a central memory T cell that has skin homing receptors, so then later, let's say you had a staph infection in your finger when you were 5, later you get a staph infection in your toe, you're gonna have that central memory T cell that knows it recognized staph here, that then can traffic in the skin when you get your toe staph infection later on in life. So that's sort of like a really basic way of thinking about it. But those T cells, once they live in your skin, it's like adults that are like, I live in Houston or I live in Austin. Like, that's where I live. This is my home. This is my job. This is where I spend my day's work. I don't leave here. And those cells, when they become malignant, become cutaneous lymphomas. So that's sort of in a nutshell what's happening. But it's very interesting. But a lot of skin disease, if you kind of go further, things like vitiligo, alopecia areata, where you have autoimmune destruction of pigment cells or autoimmune destruction of hair follicles, those are all sort of mistakes of the immune system of these T cells that live in your skin, all of a sudden recognize an epitope or an antigen that they shouldn't be recognizing. For instance, in the case of vitiligo, melanocytes, or in the case of alopecia areata, hair follicle stem cells. They're recognizing those and they're like, hey, you're an enemy, I'm going to kill you. And then all of a sudden you get a bald patch. So there's a lot of errors of the immune system. And then there can be kind of inflammatory conditions of the skin that cause overactivity of T cells, such as psoriasis or eczema, et cetera. So another thing about dermatology that I really love is the connection with dermatology and internal disease. For instance, bruising. There's a lot of different patterns that people can develop with bruising in the skin, some of which may indicate scurvy, another one which may indicate, DIC or purpura fulminans. I'm sure Dr. Fowler has seen many cases of meningococcemia in his years doing emergency medicine. And there's a distinct pattern to that type of purpura. It's not your ordinary purpura when you see it. There's these kind of little serpiginous lines that come out and they're kind of a little bit angulated sometimes at the edge because blood vessels are getting occluded and destructed. And so many times in dermatology, you'll see a manifestation of something in the skin, and it's a clue that something is amiss or awry with the internal organs of that individual. So
Hey,
there's a
Heather,
big,
for the benefit of the students, and you've got over 200 listening to you now, you mentioned one of the most awful infectious diseases in the world when you said Neisseria meningitidis.
yeah.
And it's funny that in my world of EMS, I'm a pre-hospital guy as well as an ER guy. There's a debate going around whether medics should even wear masks anymore. And I'm going, are you kidding me? You do
Yeah.
not want to inhale that stuff.
No, exactly. So, so the answer is yes. I think they should be. I really like that we can sometimes, all the doctors in our department take some inpatient consult work. And so many times a patient may be admitted for other reasons, but something will show up in their skin and they'll call us to look. And we can sometimes be the first ones at the front line that say, hey, because we see this in the skin, we're now concerned that this person is, septic, or they have they have renal disease, or they have, I can't tell you the cases of lupus that were told they had tinea or something. We look at, oh no, this isn't tinea. This is lupus or some other, there's many different instances or examples of that.
Well, Heather, I think the training in my world of emergency medicine, and we've had over 500 residents in the 21 years that I've been here. I think that the training for dermatology is way lacking. What we do is pick up the phone and call you rather than try to figure it out.
Yeah, I would advise everyone who's on the call, because I'm not going to, be able to go through everything. I mean, dermatology itself has over 2,000 different diagnoses, but there's some that are common, and there's things that are certain patterns that you can recognize. I've been part of, for the past over decade, probably for the last like 15 years, part of a working group with the American Academy of Dermatology for something called the Basic Dermatology Curriculum. It's actually free and accessible. I'm not putting in a plug for it. This is done only out of like my free time, so I get no compensation for this. And the AAD doesn't charge anything for this curriculum. But if you go online to the American Academy of Dermatology and you type in Basic Dermatology Curriculum, I think you do have to enter your email and create a password to be able to log in and access the materials. But there's PowerPoints and an organized curriculum. There's a 4-week and a 2-week rotation, and it'll really teach you sort of the basic fundamentals. So even for people that may be going to medical schools where there may not be a dermatology department, or maybe you just get, 2 hours of lecture on dermatology, there's accessible material to anybody through the American Academy of Dermatology webpage. And it's probably one of the things I'm most proud of in my career, is being part of that working group, because I feel like it's really made dermatology education accessible to in a platform that's accessible to anyone at any
Heather,
time.
we just had an interesting question. I'll go ahead and broach it and touch on it as little or as much as you want. That, dermatology textbooks, what I've seen of them, seem to mostly have rashes displayed on Caucasian skin by and large.
Mm-hmm.
Is there a cultural shift, or whatever the word is, that's happening in that area? Because
Yes, there is, which actually in that basic dermatology curriculum, one of the things that we've done is we've made note of how many cases we're showing in skin of color or in white skin. And I know for all of the lectures, I actually had their UT Southwestern, there's part of a diversity mentorship program, and one of the faculty had a student go through all of the pre-medical curriculum and see which courses maybe needed to integrate more diseases that may disproportionately affect various minority groups. And we were given a big handout on anything revolving in the musculoskeletal and skin course. Dermatology, one of our residents was actually quite interested in this topic. I actually gave her the book. I was like, hey, someone went through all our material. Will you look through this and help me see if there's areas that we need to work on here at UT Southwestern? And actually, we got a really good report and we've gotten really good feedback. We've been working on that. We have a diversity champion, Dr. Rebecca Vasquez, who I didn't mention. She has a skin of color clinic. So diseases that affect skin and skin pigmentation. We have a specialist in our department for that as well. And she's sort of the diversity champion in our department. And so we've worked hard in our department to make sure that when we're at least teaching the dermatology course at UT, that we're showing skin of color. And I know as part of the basic dermatology working group that there's also a big push to ensure that we're including images that affect all different skin types. So
thank you for addressing that. Please move on.
So another thing that a lot of people may not think about is the connection between dermatology and psychology. You know, if you have heart disease, or you have high cholesterol, or you have kidney problems, that may affect you on some level, but other people can't necessarily see your heart or see your kidneys or see your, achy hips or your achy back. But people do see your skin. And so if something's wrong with your skin and there's something disfiguring about your skin, everybody is going to know it, especially if it's on an area that, people can see. I actually sometimes think that Kim Kardashian apparently has psoriasis. And I actually wonder if that outfit that she wore to the Met Gala was because she was having maybe a psoriasis flare at the time. I don't know if you guys know what I'm talking about. It was like that all black dress. But it covered like her from her head to her toe. You couldn't see any inch of skin on her body. I was like, I wonder if she was having a psoriasis flare, and that's why she picked that outfit for the Met Gala. But there's a huge connection between dermatology and psychology. If you have acne and acne scarring, that's a risk factor for depression and social withdrawal and potentially being teased or bullied at school. And then also, there's what we call the neurocutaneous axis. So we have patients that have sort of encapsulated delusions where they'll think, they'll feel maybe a crawling sensation and they'll develop a delusion that perhaps they are infested with parasites, for instance. And so, there's a big connection between the skin and the brain, and also our social interactions with other people and how people view us.
We have a huge methamphetamine abusing population. Formication is the word, actually, which sounds a little odd. Yeah. And we see it with some regular right here. It's right. You see that bug crawling out of here? I go, yeah. If you say so.
Yeah. Yeah. I find often patients that have delusions of, delusions of parasitosis, if it's not drug induced through methamphetamines, that actually many of them have had a recent, very stressful psychological event in their life, the loss of a loved one, the stress of COVID, something happening with their home, some serious life stressor. And then sometimes they're on something like a Adderall or some sort of psychoactive medication at the same time. And then the wires get crossed and, maybe they have a scratch, and then it becomes this kind of perpetuating. It's a difficult process to break sometimes. So how many patients what's an average day look like for a dermatologist? I myself see, about 12 to 15 patients in a half day. So in a full day, I may see up to 30 patients. Generally, I see probably about 25 patients in a full day of work at UT Southwestern because I'm engaged in teaching residents much of the time. In private practice, that was definitely 30 to 35 patients in a full day of work. In private practice, I worked 4.5 days a week seeing patients, but people's schedules vary and people will tailor their schedule to what potentially works for them and also works for their employer. So I know some private practitioners that see up to 30 people in a half day, and so they'll see up to 60 patients in a full day. But those, it's not how I would want to practice medicine. They generally have a lot of support staff, and the doctor's sort of in and out of the room. I mean, I guess in dermatology, a lot of diagnoses can be made really quickly, and then they'll have their nurses or medical assistants do a lot of the education and training and kind of connecting with the patient. It's again not how I would want to practice, but people do practice that way.
So Heather, in your general office day, I imagine there are plenty of things you walk in and go, yep, that's exactly what that is.
Yep.
But how often, just very briefly, how often do you come across something? What is that?
I do, that you do. You kind of, I would say, the pink bump, when it kind of like just with a lesional growth, there is a rare time when I'll see someone, I'm like, I have to really pump the brakes and go, I'm not quite sure what's going on here. This is odd. Whatever this is odd. But generally, I still know, and I'm sure the same is true for you. You may be like, this is odd, but I sort of know my first steps. So, and fortunately in dermatology, the skin is extremely accessible for a biopsy. So biopsies are, it's not like biopsying a kidney where you're like, well, your kidney's failing, but we don't know why, we're gonna have to biopsy it. You know, that's a big deal to biopsy someone's kidney. The skin, not such a big deal. You know, it's right there. You just do a little local numbing, you take a small sample, and your pathologist helps you out with like, okay, it's got this pattern. At least you can say, okay, the differential was here, and now we're going to narrow it down to here and here. But, you know, certain things, it's like if you had I don't know what color your mom's hair is, but everybody think of your mom and what color her hair is and what her stature is and what her body build is, etc. If she was a room full of other women that looked just like her hair wise and, you know, body habitus wise, but they were different people, you would still be able to pick out your mom. And so dermatology is highly pattern driven, which I love from my art background, because I'm like, it's like art history. You're like, that's a Monet, that's a Van Gogh. They look certain ways. You can tell them apart just by certain patterns. And dermatology is a lot like that. You know, certain things only look certain ways. And when you see it, you're like, I know this like it's my own mother. And so, you know, I'll have a patient that has a seborrheic keratosis, and I'm like, that's a seborrheic keratosis. And I'm like, how do you know? You know, I was, you know, and I tell them the mom story, and they're like, oh, okay, you know, once you've seen something 1,000 times, you can recognize it. But then, you know, when you go, oh, I look at this, and I'm like, well, it's not a seborrheic keratosis, and it's not a mole, and it's not a basal cell. Can't really tell what this is. I'm not quite sure. It's suspect. And so, if it's suspect, then you take a biopsy, and then the pathologist helps. So,
my world in the ER is so much cellulitis, of course. We see loads of nail fungus, as you might imagine, especially among the homeless population. And about as complex as we get trying to name it is pityriasis rosea. And then when it hits on psoriasis, we usually give you a phone call.
Yep. So I love it. I mean, it's a lot of fun. So it's really cool. Okay, let's see here. Let me uncover. So what are the hardest parts of dermatology? Well, if you get, as you can tell, I don't get tired of talking. So I talk to a lot of people all day. And so sometimes at the end of a long day, if I've been talking to a lot of patients that had a lot of questions, that can be tiring. And you may come home, you know, I come home sometimes to my loved ones, and I'm like, I'm just really tired of talking to people. And, you know, I kind of sometimes don't feel like talking much when I get home. But I have to sort of muster and gird my loins and, you know, still be there for, you know, friends and family. But that can be hard, and that can be draining. So it's important to be self-aware. And I think you probably see this also, Dr. Fowler. I think people sometimes fall in love with the idea of something, but then the reality of that is different than what it actually is. And so I had, you know, like I said, I had a brief flirtation with trauma surgery, but I had enough insight to know, hey, you know, I like sleeping at night, and I'll have a hard time if I get woken up in the middle of the night for the rest of my career, even though it seemed really cool and really appealing. And even on some levels, I still think it seems really cool and really appealing, because it shares something similar with dermatology, and that's that you get these kind of really weird, rare traumas, and there isn't a textbook to guide you through how you deal with it. You deal with it, you know, sequentially and in a process, but it's not like, you know, I don't know, bypass surgery that may be like very rote. And so dermatology is also like, a lot of times there's a little bit of free form with the medicine, which I like.
Well, you know, Heather, the flip side of that, it reminds me of something my old pappy said, which was, human nature is what humans do. And it is so normal, or at least it is so average and typical, for people to deny that they have a problem and that not wanting to face it. And so very often waiting forever to come in. I saw a guy one time with a basal cell that had eaten half of the side of his head. He ignored it. And by that time, the basal cell was metastatic. How often does that happen?
No, not very. No, I can say in all my career so far, I've not yet had a patient with metastatic basal cell, but I have had the half face basal cell, or the ear gone basal cell, or the eating into the cranium and the calvarium and the periorbital skin and the loss of an eyeball basal cells. I think there is, as part of human nature can be that sort of, I think that's like what keeps people from doing health screening behavior. It's like we're my significant other, he's always saying, it's like, I'm like the zebra on the safari in Africa and the lions are over there. And I'm like, if I just sit over here eating this grass, num, 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 the lions can't see me. If I don't look at them, they don't see me. And so there's a lot of temptation, I think, in a lot of healthcare for people to want to ignore problems, because once you face it, it's all of a sudden now it's real.
So talk about that last line on your slide, fighting with insurance plans.
That can be hard.
All you 200 plus kids out there, you're wanting to get into medicine or a medicine related career, PA, NP, and so on. Prepare yourself for this. And you want to talk about it, Heather, about the insurance plans and what they do and don't do?
Yeah, it's a constant, I will say that it's only gotten worse over the years. I've even gotten things like prior authorizations for things like oral prednisone, which is like $1 a pill. And the insurance was asking me to fill out additional paperwork to explain why I wanted the patient to take a prednisone course. And when a patient needs prednisone, they don't have like 2 or 3 days for me to sit and fill out a form and fax it in, wait for the prednisone, like they need the prednisone like right away. And so, and then it's very frustrating to be like, we're doing this paperwork, but it may take a bit. You're going to have to fill some of the prescription and use GoodRx, and like the patient's paying out of pocket when their insurance plan. That's extremely, extremely frustrating to deal with. Or, depending on what kind of environment you're in, we work with nursing staff, but sometimes our one insurance plan's prior authorization may ask questions A, B, and C. And another insurance plan's prior auth for the same drug may ask questions E, G, and F. They ask different questions for the same drug. And so when you're documenting, and when I'm documenting, okay, I'm seeing patient X, they have eczema, they've used this, this, and this, and now I want them to use drug Y, and I'll put it in my note. But a lot of times insurance plans are like, have they failed drug A, B, C, and D? But I was like, well, they failed drugs D, E, and F. And my nurse, and I don't have every single drug from every single thing from all of their history in the note. I've got like the basics to like why I want to do what I want to do. And then the nurse is just going off of my note, and they don't sometimes always ask me, hey, and they're like, oh, well, I filled it out, but you didn't have like, and I'm like, why didn't you just come and ask me before you just sent this form in? Because it gets denied. And then I have to go to what's called a appeal, where you have to sometimes do a peer-to-peer and you have to schedule that. And I would say that I write probably like 5 or 6 appeal letters per week to get drugs that patients need. And that's hard.
And each of these take time. There was an article yesterday in one of the medical rags about that very thing. They call it the unknown patient, that some patient listed this doc as being his doc, and the doc has to take time out of 4, 5, 6 of these a day. Each one takes several minutes, and hours add up.
Yeah,
it's a real mark of what's unfortunately difficult about medical care in our country today.
Yeah. So there's this doctor I follow on I follow his YouTube channel, but he's on TikTok, Dr. Glaucomflecken. I don't know if anyone ever watches. He's hilarious. He's really, really funny. And he has a whole thing on like prior authorizations and how it's like insurance companies like practicing medicine because they're kind of telling doctors what to do. But, it's challenging. And it's definitely not, I would not say that's a part of my job that brings me joy or is rewarding. But when you win one, it feels really good, So, yeah.
Please keep going. This is a terrific talk. We got so many positive comments already.
Let's see here. Okay. So what does it take to be a dermatologist? Well, I would say for sure good grades. And I would say strong mentorship and research. So connect with a mentor early. If you go into medical school and you want to go into dermatology, connect with a mentor early. It's never too early to at least think about developing a niche, or at least some area in which you can do some good research and maybe get some publications. I would say try to be, if you're good at visual diagnosis and pattern recognition, it's also good. And then I would say that, what we were sort of talking about earlier, where you have to have a little bit of a tolerance for ambiguity, meaning in derm, there's a lot of very, very rare diagnoses that don't have clear-cut textbook answers about what do you do? What do you do for case, A, B, or C? There's not like, there's not a book that tells you this is what you're supposed to do. It's not like, in any medical career, there's going to be some area where you're like, this is a little bit off the normal beaten path. Like there's treatment A, B, and C, even in like cardiology, for instance, there's going to be, but in things like cardiology, it's a lot more, I would say, by the book. And it's only in these really challenging cases that you're going to be like, okay, let's combine therapy A with B with C to see if we can get you to a better place. In dermatology, you may have some really rare disease and there's no known really good treatment. So you have to go, okay, well, I understand the basic science of what underlies this disease, at least what's known about this disease. And then I know over here, we have this set of drugs that may work on the inflammatory cascade or pathway that's involved in this really rare entity. And so I'm going to apply creatively this drug that's designed for something else to treat this disease that like nobody knows about or understands. And that's
so Heather,
pretty cool.
Is it true about dermatology that go examine the patient, describe to yourself what you see, translate it to Latin, and you've named it?
Pretty much, yeah.
Erythema multiforme,
yes, exactly. So knowing the mechanism of action of various drugs and then the scientific underpinnings of a disease process can sometimes help you pair up a drug with a disease in a unique and creative way and come up with a therapy or a solution for a patient that may not have been thought of before. So that is really cool and that's fun to do. Let's see here. Okay, so I see, as I mentioned earlier, about 12 to 15 patients in a half day. So that's about one patient every 15 minutes. Most academic dermatologists work 6 to 8.5 days per week. If you think of an average work week having being broken into 10 half days, most academics are going to have 3 to 4 half days. We have every Thursday morning is grand rounds, so nobody is in clinic on Thursday mornings for at least the first 2 hours on Thursday mornings. So that's already subscribed for grand rounds, which I love because it's like an opportunity to learn each week. It's one of the things I love about academic medicine. It's like I'm surrounded by smart people that are way smarter than me that I get to learn from each week, which I love.
Our world in the emergency department is 8-hour shifts, typically about 4 a week. Mornings, afternoons, and overnights.
Yep.
And I'm old, I'll be 70 this year, and I have to work with a resident. I don't want to work alone.
Yeah.
Because Epic alone is so complicated. There's so many buttons to push these days for the medical record.
Yep. So I said not 10.5 days, 10 1/2 days. So a 5-day work week, Monday through Friday, is 5 full days is 10 half days. Does that make sense?
Yes.
Okay.
Yes.
So not 10.5. Yeah. And so what medications do we use? We use topical medications, oral medications. We even use psychiatric medications, as I mentioned, with the psychiatry dermatology connection. I've put patients on antidepressants. I've used antipsychotics in the cases of patients that are, have delusions of parasitosis. A lot of the psychiatric meds have antipruritic effects, meaning they reduce itching in the skin. And then we use often, because of the immune activity that's in the skin, sometimes autoimmune diseases will disproportionately affect the skin. So we often use really strong immunosuppressive medications, chemo type medications like methotrexate, mycophenolate mofetil, rituximab, etc. So yeah, delusions of parasitosis it's like an encapsulated delusion. It's a fixed false belief that you have a parasite infecting your skin.
So, so you have a disease, say like cutaneous lupus. We'll start it with, let's say lupus you see on the skin. And you look at the patient's lab work and they have proteinuria, and clearly they're having stuff on the inside happening as well. Do you regularly coordinate your work with specialists in fields that you think, rheumatologists, for example?
Exactly, right. And in cutaneous lymphoma, we used to have an oncologist, and he and I used to do clinic together in tandem. We'd see patients back to back. That was great. He actually moved on to his job took him to Florida, but I have two hematologist oncologists. I have their cells, and we will text. I have my radiation oncologist on text, and I'll say, hey, I've got a patient in clinic right now. I need you to get them in this afternoon and do X, Y, and Z. Can you work with me to get this patient coordinated? And they'll get them in that same day or within that week. So we're constantly in contact with one another, for instance, for the lymphoma patients that I see.
So in looking at the list of the drugs like the immunosuppressive and chemo, it's funny, I asked the residents, so who watches CNN? Nobody. It's only me. But if you watch CNN, you have 5 minutes of programming followed by 5 minutes of commercials. And the first 2 minutes of the commercials are all the new immunologics, the new abalabamabs that are out there. So do you see a lot of change in your field with the new immunologics coming out?
Yes.
Humira for psoriasis, for example.
Exactly. Yep. Absolutely. 100%. And there's new ones coming out all the time. There's one for atopic dermatitis called Dupixent, which is, I think, omalizumab, or no, that's Xolair. So there's, which is an anti-IgE monoclonal antibody. So yes, there's a monoclonal antibody being developed. I can tell you in the pipeline, there's probably hundreds of thousands of monoclonal antibodies that are in development right now. The hot new side.
Yeah. So you got a guy with really bad psoriasis or a gal, and you want to put them on, let's say Humira. I'm just using that drug for a moment. And the cost per year is $60,000 a year.
Yeah.
How in God's name do they afford that?
So, what's interesting is that a lot of the drug companies, like with Parkland patients, Parkland Care is not considered insurance. So those patients actually are very low income and generally will qualify for free drug through the drug manufacturer. But if you're underinsured, it's a lot more difficult. Or if you're a Medicare actually patient, those patients actually, it can be difficult if you have Medicare to afford the co-payments, because you're right, the co-payments on some of these drugs can be as much as $1,000 a month or something. And so and if you're on a fixed income, it's just not tenable or feasible. And so some of the drug companies will have assistance programs. There's foundations that patients can apply to get copay assistance, but you have to have a very motivated patient, actually, like usually some devoted office staff or access to social workers, people that can connect the patients and help them, patient care navigators that can sort of help them, fill out paperwork and fill out forms and see if they can get copay assistance. So it's definitely not always easy to get patients the drugs that they need. So yeah, monoclonal antibodies for sure. One of the hot new cytokines that people are targeting in dermatology or looking at targeting is IL-31, which is the kind of one of the big itch cytokines. So how do I manage work-life balance for myself? Well, I really I don't take the phone to the dinner table. One of my friends, she's a great friend from medical school. Well, she and I talked about it. And she was like, she does not take her phone to the dinner table. She's like, dinner time, before the era of cell phones, you would maybe have had a pager, but people would only page you if it was a real emergency. Nowadays, when people have your cell phone, people text just offhand about anything. And people expect relatively immediate replies. But there's almost nothing in dermatology, and that is someone's going to die like that second if I don't answer in 30 minutes or 1 hour. So I feel like that really, the only person that can protect that time is me, and I'm the only one who can infringe on that time on myself. And so I decided that other people may text and they don't know when I'm having dinner. They're just asking a question. And I can either choose to have that invade my dinner time or not, and I choose not to. So I keep the phone away from the table.
The standing joke on virtual shadowing is that I have a flip phone.
Yeah.
And I actually made that as a for real, not a conscious choice, because I don't want to be on the computer all the time. And I know I will be. I'm on it enough as it is.
Yep. So I keep the phone off and I keep it away from the table during meals with family, except when I'm on call. When I'm on call, I'll have it at my side, but I have it turned over and I have it, I have it where it'll ring. And if I see or make a chime, and I'll flip, if it's something with being on call, then I'll deal with it. But if it's not, I turn it right back over, ignore it until dinner is done. So I really, I block that time. And then I really try to block time on the weekends. So just 1 hour or 2 hours to just do a task. And when that time passes, I try to close off what I'm doing and not let it run and bleed into the entire day and take over my day. I try to do most of my work when I'm at work and try and leave work when I leave work, not log in and not check charts. I really try to not open the patient chart or patient record. I try to be highly efficient when I'm at work and get everything I need to do. I eat at my desk. I eat lunch at my desk. I answer notes at my desk. So my lunch is not protected, but I'm not having to be around family at that time. And so I look at that as this is my work time and I get as much done as I can. And I just jam through as much of my day. And then, as I mentioned, when clinic is done, I try to close out all of my charts, clear out my inbox. So when I leave, I know it's a clean slate. Whatever comes in overnight, I'll deal with the next day. And so that's sort of how I encapsulate and manage it. But burnout rates are increasing. That's something students going into medicine should be aware of. I don't think, medicine attracts, and I'm part of this group, medicine attracts people who are born people pleasers, who want to help people and are driven by a desire for myself. I desire myself to help people and be a good citizen and be a hard worker and push myself hard. And so what can happen is that a lot of times the decisions that are being made about volume are being made by people, and I'm not trying to vilify it with MBAs or administrative people, but sometimes when you have, I feel fortunate because I'm part of a department where the decisions about patient care come from our chair, our chairman sort of heads the ship and is very protective of us as faculty. And I'm lucky for that. And so if you have someone who's just driven by money, you can get where you feel like you're on this treadmill and slowly someone's turning the speed up. And at first you don't notice it. And then all of a sudden you're like, wait, I'm getting 20 denials on prior authorizations per week because some MBA and bean counter is saying, let's put in denials for all the prednisone or whatever, and then some other MBA that's running the hospital system is like, let's add one patient to everybody's half day of clinic, which doesn't seem like much. And then next year it's 2 patients and the next year it's 3. And so as the heat, it's like you're the frog in the pan, that slowly the heat gets turned up and you don't realize it. So I do think it's important for physicians to have a voice at the table and to participate in things like faculty senate and, the places where you can raise your voice and to be involved in the decision making.
I think, Heather, this doesn't, with the burnout rate you mentioned, I don't think it necessarily means that people quit. It's just that they get really fatigued. What is the word? What's the emotional word? Not emotionally challenged, but it's whatever that word is that has to do, morally injured is the word I'm searching for, in their line of work. I was working for a private hospital over 30 years ago, and when the Press-Ganey scores started coming out, and for the students, that's where we get ranked on patient satisfaction. And back in those days, the ERs were where people came for their narcotic scripts for their migraines. And when we just didn't want to participate in giving out narcotics, we would get terrible scores from patient satisfaction. And you go, I'm trying to do the right thing,
Mm-hmm. Yep. So yeah.
Please rock on.
Yeah, so this source was from the AMA. This was just straight off of their website. So I was like, well, what is the burnout rate in dermatology? I don't know. There's times I feel like I try to be self-aware when I'm feeling burned out and when I need to take a vacation. And I think it's important to anticipate when if there's a certain interval. I notice if I go longer than about 3 months without a vacation, I'm going to probably start feeling burned out. And so I'm actually coming up on that, and I'm having a vacation later this month. So that's partly why Taylor was so helpful putting this talk together, because I was like, I am feeling stretched kind of thin right now. So it's important. So what can you do to maintain work-life balance? So, the hospitals, part of it, the job has to fall on the hospital system to take care of the physician, but it's also our job to recognize when we're feeling burned out and to set time aside and protect your own time. So it is important to set time to do something that you like doing, to actually schedule vacations, and to exercise, and talk to the others in your life that are significant to you, and to do the hobbies that you like. I often talk with some of my patients are physicians, and some of them are retiring or close to retirement or have recently retired. And I'll ask them, how are you enjoying your retirement? And what are you doing in your retirement? And one of the doctors I see is like, start your hobbies now. Make sure you're doing your hobbies now. Engage with your hobbies now. Figure out what's important to you and make time for that. And so it's never too early to develop hobbies. During medical school, I will say I stopped doing all artwork. I was a total student. I was just nose to the books, all of that. But since I've been at UT Southwestern, I started taking some pottery classes. My significant other, his daughter and I do art projects together all the time. I love spending time with family and with doing arts and crafts related activities. It's very rewarding for me. So I try to make time for that. Okay. So this is a list. This is actually not a, whoopsie, sorry, that was, sorry, that's I took those slides from another lecture and I had a voice recording over it. So let me just go back here and
yeah, I think that was in your case presentations, wasn't it?
Yeah, it was. Sorry about that.
Well,
there's a lot of cutaneous lymphomas. Here is an image of mycosis fungoides, which is the most common of the cutaneous lymphomas, but it itself is extremely rare and only affects 6.4 per million per year. So it's an extremely rare lymphoma, but it's the most common cutaneous lymphoma. And this patient on the right may not look like they have skin of color, but that's actually a Hispanic gentleman on the right-hand side. So it affects African Americans more than whites, and generally is indolent, but can be aggressive, and patients can die of it. What other things do we do regularly? I do a lot of cosmetics. We use lasers, we do chemical peels, Botox, fillers, all of that. We do, or I do, at least in my practice. So I just went through, I've added like 3 cases. The first case is a patient here, a young woman with nodulocystic acne that's clearly leaving scars and potentially permanent marks on her skin, with examples of post-inflammatory hyperpigmentation. That's that dark pigment here off to the side, but these sort of pockmarked, rolling and ice pick scars. So this is a patient, if they walked in, I would not hesitate to put this patient on oral isotretinoin or oral Accutane, because the best way to treat acne scarring is to prevent the scarring to begin with. We may have a whole armamentarium of peels and lasers and microneedling and all sorts of stuff that purport to fix acne scarring or correct acne scarring, but the best results for scarring is to not have the scar to begin with. So we potentially want to get this treated as quickly as possible, and isotretinoin or Accutane is the quickest mechanism to do that. Here is the second case that I wanted to kind of just show to you. And this is a patient with an example of what some people might consider a cosmetic issue, but still can affect someone's psychological well-being, because most people don't want to have to use heavy cover-up. They want to have natural, even-looking skin. And this is an example of melasma, which is a form of chronic UV damage in medium brown skin tones that can be treated with a variety of pigment lighteners, retinoids, topical steroids, and things that inhibit the melanin synthesis pathway. Melasma, that's correct, Ruby. And then last, I just have 3 cases that I wanted to show examples of. The first 2 are sort of bread and butter dermatology. This one may be something that we would see in consults or as an urgent overbook. And this is a patient with what we would call a morbilliform eruption, which just means that it resembles measles. So this is sort of a distinct kind of papular, can be also macular, patchy, pink to red rash. In brown skin, this may look more purple to tan. This is an example, as I mentioned, of morbilliform eruption. An exanthem is another term that you might call this. An exanthem just means it's a rash that showed up relatively immediately. So it was, I didn't have a rash yesterday. Today I woke up and I have a rash. Only certain things do that. When you're like, I didn't have a rash, now I do. The most common things that make you wake up with a rash that you didn't have the day before are going to be bugs and drugs. So viruses and medications. And then so the first question is, do the patient feel well or unwell? Do they have sick contacts? Do they have new medications? If they, have sick contacts, then you go down that path. Or if they're younger, then you go down that path. But if it's new drugs, you find out what new drugs and what the order is and what the timing is. If it's within the last 1 to 2 weeks, you worry about something called Stevens-Johnson. You always want to do a mucosal exam to see if there's oral erosions. If there are, then you think of this bad drug reaction called Stevens-Johnson. If they don't, but they have maybe fevers and chills, there's another thing called a drug rash with eosinophilic and systemic symptoms. It can cause kind of a systemic inflammatory process. We call it DRESS for short. So a morbilliform eruption is, again, like one of these differentials. You walk in and you're like, well, I don't know what caused this yet, but I know only certain things do this. So when someone shows up with a rash they didn't have yesterday that's there today, I know they either have a virus or they have a medication. And it's one of those 2 things. And it's my job to sort of parse out what it might be. And then through a series of other questions, Stevens-Johnson is usually most commonly associated with what we call the Satan medications, which are sulfas, azathioprine, anti-seizure medications. T is tetracyclines, and N is NSAIDs. So those are the most common. But sulfa-based antibiotics are probably the most common. Anti-seizure medications are probably the next most common. So, the really severe version of Stevens-Johnson is called toxic epidermal necrolysis, and that's where someone may blister and peel off all their skin, and it can be fatal. So, and then DRESS can also be very bad because they are getting sort of systemically inflamed and they need prednisone, et cetera. But that usually is a longer drug exposure, but it's caused by the same medications that cause Stevens-Johnson. So, so that's sort of the last. Those are my only 3 cases. I'm sorry I don't have more cases, but I'm happy to answer any questions at this point that anyone may have.
So is it true? So is it true, Heather, that there really were only 3 treatments in dermatology? If it's dry, wet it. If it's wet, dry it. When in doubt, put a steroid on it.
That's pretty much all we do.
Sorry.
No, it's totally true.
It's just like, how do you hide $20 from an emergency physician? You put it in the past medical history.
Yep.
Please finish. And we've taken a lot of your time already. Just to wrap up, and we have just a few questions for you.
So again, just like if you're interested in dermatology, you feel free to email me, but you can pretty much anyone in our department. Their emails at UT Southwestern are first name dot last name at UT Southwestern. That's the secret to emailing faculty. I just gave away like how to email anyone at UT Southwestern. But basically, that's how you can reach anyone who's a faculty member. I think that it's actually not. I think it's probably also public information what our emails are. So, you want to find a mentor. You want to do research as early as possible, and truly do get good grades because most schools still form some form of a class rank. And so if you're in the lower half of your class, it's can be a virtual impossibility to get into dermatology, unfortunately. At least I know here it can be.
The operative word on that, Heather, is that you're going to sweat bullets to get into medical school. And then after, deep into medical school, you're going to have to figure out what you want to do. And then you're going to find that many of these specialties are exceptionally competitive. We had Dan Septimon from Family Medicine, and for their 12 residents, they had 1,300 applicants.
Yeah,
we get about 1,800 for 26 spots, but look at you get 500 for 5 spots. Holy cow!
Yeah. So, having a mentor also, that person usually is going to be involved with the admissions process. So they're going to be able to help guide your personal statement, writing good letters, and also be an advocate for you in the actual ranking process for the residency where you may be applying, or know people across the country that they can call and say, hey, I know this great medical student, you guys should really look at interviewing them or whatever. So, yeah.
Okay, did you say you were ready for some questions?
Yes.
Okay. So one of the questions that we got is, what are some personal characteristics or strengths dermatologists tend to share? Who are the people that should really consider dermatology?
Well, I think all dermatologists are a little bit creative because we deal with a really rare set of entities. I think that most dermatologists are somewhat visually oriented. And I would say most dermatologists really are, I would say the successful ones are intellectually curious and continue to want to read and understand the basic science of the skin, because I think that really is what makes a great dermatologist. So people who are curious, for sure.
Okay. So one personal question I had. So what are your thoughts on Accutane? Do you believe that it is the strongest and most efficient drug to use to treat severe acne? Are there other drugs you might consider using?
Well, like in that case I showed you, I mean, I would really be advocating for that patient to take Accutane or isotretinoin. It causes apoptosis or apoptosis, however you'd like to say it, in the sebaceous gland, which is the driving force behind acne. And so it's one of the there's very few diseases in medicine where you can be like, I'll give you this medicine that you take for the next 6 months. And after the next 6 months, you will no longer have hypertension. Or at the end of the next 6 months, you will no longer have kidney disease, or you will no longer have diabetes. So we're taking what's normally a chronic condition that's going to cause permanent scarring and disfiguration of an individual, and we're fixing it in 6 months, and they're done and their skin is fixed. So we're taking what would normally be a chronic, incurable, or difficult to cure condition before someone grows out of it and is potentially disfigured by it by the time they're middle age, and curing them of it within a 6-month period. And there's very few, I can't think of very many other medications that do that for people. So I'm a big fan and a big believer, and for patients of mine that may have some Accutane hesitancy, I try to find out what it is that they're worried about, find out what it is that they're concerned about. Generally, they've gotten some medical misinformation somewhere along the way. And I try to correct whatever fears or concerns, or allay whatever fears or concerns that they have, so that they will hopefully adopt the idea of taking the therapy, because it does work, and it works very well, and it's highly effective. And most of my patients that I can't think of a single patient of mine that's taken it that's like, wow, I really wish I hadn't taken it. I mean, I've had patients that as soon as a little pimple comes back, they're like, I need more. And I'm like, you don't need more yet, Yeah.
Yeah. I mean, I took it back in 8th grade, and so I'm 23 now. So I can say that it works. And
it's a game changer for sure.
Another kind of along the same lines is, what is your professional opinion on cosmetic products, I guess topicals maybe, that they sell over the counter that contain medicinal ingredients that lower than prescription drug concentrations?
Well, I mean, I think for people that may not have access to regular medical care or prescription medications, they're fine, and we recommend them for people that may not need, full prescription level of medications. Like topical retinoids do work. They don't work as well as a prescription retinoid, but over-the-counter retinol does do stuff. Over-the-counter hydroquinone's you're not able to purchase anymore. But there's a topical called topical tranexamic acid for melasma, for instance, that does work. The oral tranexamic acid is a medication used off-label in dermatology for melasma that's actually used normally to treat postpartum hemorrhage, but happens to inhibit melanin synthesis. It's used off-label. That's an example in dermatology of how dermatologists are like, we have this condition, like melasma doesn't respond to a lot. What do we do to treat it? Oh, we found this drug and that works for postpartum bleeding, and it works on this pathway, and now it happens to like inhibit melanin synthesis. What if we give women that pill that's not at half the dose and then see if their melasma gets better? And whoa, wow, it does. Wow. And now people write for it for melasma. So that's one of the examples of what people do in dermatology and that I like.
Okay. Dr. Fowler, do you have any burning questions that you've been wanting to ask? Well, so we close up.
Only in as much as that it's really interesting what's happening. I was reading in Science Magazine today, I am a geek, talking about T cell analysis in cells, especially trying to get the numbers of the skin resident memory T cells, and are actually able to classify the clinico-pathologically ambiguous rashes with diagnoses that are consistent with therapy, which I think is, I guess that's kind of the way of the future.
Yes.
They even did a website called Rash X, so that docs could send in their biopsy specimens and form a large database.
That's actually kind of cool because there's different T cell subtypes that cause atopic dermatitis, then psoriasis, then drug rashes, etc. So there's different classes of T cells. So then you could be like, oh, okay, well, we'll pick, we know this drug inhibits this T cell, like, IL-23 works on this, or IL-17 inhibitor. So you could pick a monoclonal antibody that's targeting the T cell that's your, target T cell. That's kind of cool.
Well, Heather, what a wonderful presentation. We've taken a lot of your time tonight. We're going to post this talk online, and typically about 5,000 of our students will watch the talks. Each one of them will have a career in healthcare and probably see 100,000 patients. 5,000 times 100,000 is 500 million. You've touched 500 million patient lives tonight through your kindness and your grace and your amazing skill and intellect. So we are deeply, deeply grateful. Well, folks, we're going to bring it to an end. So can you go forward a slide or two?
Just to the last slide with the QR code.
And
I meant to put this closing. This is one thing I really believe strongly, that truthfulness is the foundation of all human virtue. So be honest in your career, be helpful, and whatever you do, try to give back. It's important, I think, in life, you can always make new friends, but you can't make old ones. So find good friends along the way and do all you can to keep them. There is not ever going to be a perfect time to have a family. So if you want children, have them, when you find the suitable partner and all of that, or not, because the window closes on reproduction. And so if you want children, don't necessarily delay that for the perfect time, because there's often not a perfect time. And then continue to learn and be curious. And then here is that it? No.
Is the QR code on there, Taylor, or what? Go to the very end, slide 28, Heather. One more down. Taylor or Adidia, what do we need to do about? It looks like it's in chat for you.
If I can share the screen really quickly, I can show it.
Yeah,
okay,
unshare
here.
Heather and Taylor, if you would.
Okay, I'm going to sign out because it's bedtime over here, which I need to go attend to.
Thank you so much, Heather.
Take care. Thank you. Bye-bye.
And Taylor, do you have a QR code for us?
Yeah, of course it's saying like asking me about system preferences. I can just send it in the chat actually, if that's okay with everybody.
And I believe Adidia has just put the quiz link. All the students still on, would you please look at the quiz link that's in chat right now?
And I'm going to send the other one as well.
And the session 23 YouTube video and exam is in also in chat as well. So let's make sure that everybody gets a chance to copy it.
Okay, so I just sent it in the chat, the quiz 99 quiz. Okay, he put both of them in there as well. All
right, everybody get a chance to copy it. And in 20 seconds, we're going to sign off. We want to thank you all for coming on behalf of Dr. Goff, who just, what a marvelous presentation. And on behalf of the whole virtual shadowing team, we are just very grateful that you join us week after week. We hope we're making a difference in your futures, and you certainly are making a difference in our lives by coming week after week. So on behalf of the whole team, Dr. Goff, we want to say thank you for coming. We hope you have a great evening, and